Hey GI care team, have you ever cared for a patient with a distended abdomen, no bowel movement for days, and sudden cramping? They may be dealing with a large bowel obstruction, or LBO, a potentially life-threatening condition requiring prompt diagnosis and intervention. Let's explore what causes it, how to treat it, and what nurses need to do to keep patients safe and comfortable. Large bowel obstruction occurs when the normal passage of intestinal contents is blocked in the colon. Mechanical causes include colorectal cancer as the most common cause, volvulus or the twisting of the bowel, often in the sigmoid or cecum, diverticulitis with stricture, hernias, adhesions, which is less common in colon versus small bowel, fecal impaction, functional obstruction, or pseudo-obstruction, Ogilvy's syndrome, which is often in critically ill or elderly patients. Blockages lead to distention, fluid accumulation, electrolyte imbalances, and can result in perforation, peritonitis, and sepsis if untreated. Alright, let's dive into the symptoms and diagnostic evaluation. When it comes to classic signs and symptoms, here's what you need to look out for. Abdominal pain that starts colicky and then becomes constant. Distension, nausea and vomiting, sometimes fecal in the late stages. An inability to pass stool or flatus, high-pitched bowel sounds early on that may become absent later. And if perforation occurs, you might see tachycardia and hypotension. Now for the diagnostics part. An abdominal X-ray can show dilated bowel loops and air fluid levels. A CT scan is really useful as it identifies the obstruction location, its severity, and any complications. And don't forget the labs. WBCs can indicate infection, while electrolytes and lactate levels can point to ischemia. A medical treatment for partial or stable cases includes keeping the patient NPO and using an NG tube for decompression. IV fluids and electrolyte replacement are essential, along with bowel rest and close monitoring. Addressing the underlying cause is crucial, for example, using enemas for impaction. For complete or complicated obstructions, surgical intervention may be necessary. This could involve resection of the affected bowel with or without colostomy, detorsion or resection of a volvulus, emergency laparotomy for perforation or ischemia, and even stent placement for some malignancy-related cases. Initial care involves assessing abdominal girth, bowel sounds, and pain levels. Maintaining strict NPO status and managing NG suction is critical. Monitoring intake and output, as well as electrolyte trends, is also important. Positioning the patient upright can help reduce pressure. Ongoing monitoring should include watching for signs of perforation, such as sudden pain relief, a rigid abdomen, and fever. Assess for dehydration and worsening vitals, and administer IV fluids and pain medications as per protocol. Patient education is key. Emphasize the importance of a bowel regimen and fiber intake post-recovery, and inform them about signs to report, such as severe pain, no bowel movement, or vomiting. Prepare them for possible surgery or stoma care if indicated. Complications to watch for include bowel ischemia, sepsis, peritonitis, electrolyte imbalance, and respiratory distress from distension. Large bowel obstructions are dangerous if missed, but with thorough assessment, timely intervention, and strong nursing care, we can help patients return to comfort, function, and health. Got tips for managing GI patients? Share your experience in the comments. Like, subscribe, and follow for more GI and emergency care tips built for your clinical toolkit. And remember, relieve the blockage, monitor closely, empower the recovery.